Okay. Well, hello, everyone, and good afternoon. We are so glad you could join us today for this topic, and we are delighted to have a special speaker joining us today as well. So, the Society for Digital Mental Health, or SDMH, as you might have seen, was founded in 2021 to bring together researchers, clinicians, technologists, policymakers, and advocates, all working towards one shared goal to make mental health care more accessible, evidence-based, and equitable through digital innovation. Today's conversation gets right to the heart of that mission: CMS reimbursement for digital mental health technologies. We all know that reimbursement isn't just about dollars, it's about making sure innovative tools actually reach the people who need them and that providers have the support to use them responsibly and sustainably. At SDMH, we believe the future of mental health care depends on bridging policy, evidence, and innovation. And today's discussion is a big step in that direction. So thank you again for being here, and we're excited to dive in. So when we look at the growing mental health app market, we can see the rough estimates here. And it's a sign that digital mental health is becoming an integral part of modern care. So this isn't just a tech trend. And the recent Peterson Health Technology Institute published their 2025 digital health purchasing findings, which some of you might have seen. And these solutions are really focused on diabetes, but mental health as well. Health plans and health systems are increasing their investments. And we are also seeing improving access to care as a top priority for purchasers. So when we look at psychiatric disorders, they really do represent a major public health challenge in the United States. We know that 1 in 5 American adults actually did report a mental health condition in 2022. And these are not often in silo, right? They exist rather intertwined with social determinants of health, such as housing and financial security. So because of this rise in the app market and ongoing mental health treatment challenges, what we saw is in 2024, the FDA and CMS actually collaborated to establish new payment pathways for digital mental health treatment, which is an important step toward aligning regulation, reimbursement, and access to innovative mental health care. Which leads me to announce and introduce our speaker for today, Michael Schellhous, Esquire from the Nixon Law Group. We are delighted to have you with us today, and I'll turn it over to Michael.
Thank you so much, Lisa. I'm really excited to be here today for the discussion. This is an area that's really close to my heart as I see it continue to evolve. So just my introduction, as Lisa said, I'm counsel at Nixon Law Group. We are a law firm that's focused entirely on innovation in healthcare. And so we take the approach that innovators and stakeholders in this space have a lot of different concerns as they're trying to build innovation, make an impact in the space. And we want to support that as much as we can through an integrated approach to your legal needs. And so we look at how do we combine your regulatory strategy with your reimbursement pathways, with your IP considerations, with your contractor negotiation and discussions with payers, with your general corporate work and everything that goes with building a space within healthcare innovation. Each of us also has our own areas of specialty. And as noted there, my area of specialty is kind of the FDA and federal regulation of emerging technologies within this space. So everything from FDA submissions and strategy to reimbursement pathways emerging with CMS and with other payer systems is really where I love to dive in. So as you can tell, this is a topic that's right up my alley to discuss. Um, just a disclaimer, always have to put that in there. While I am an attorney, I am not your attorney unless you've signed an engagement with our law firm. And so just to keep in mind that today's conversation is for informational purposes. We want to dive into the details, but nothing here should be taken as legal advice. So I wanted to start here just kind of setting a baseline with some of the terminology that we have. The terminology within this space has evolved quite a bit over the past 5 to 10 years as technology has evolved as well. And so we need to be careful when we talk about innovations in this area that the way that we use terms in the industry lines up with whatever agency we're talking about, right? Some of these terms have very specific meanings to the FDA and very different meanings to CMS when we talk about our reimbursement pathways. So I just wanted to set kind of the baseline of how we're going to go through the discussion today. The first thing I'll note is that CMS and FDA generally use different terms when they talk about mental disorders or behavioral health conditions under different situations. CMS was very clear in the last physician fee schedule that we see that they don't intend those to have different meanings. They intend their meaning to align with FDA in the broadest way possible and include any kind of psychiatric disorder, including substance use disorders. And so they're not trying to limit anything by using that terminology in this space. We sometimes see that in other areas, so we want to be mindful of that, but they're not currently looking at that here. We also have here the digital mental health or DMH technology term or products, DMH products. This is a very broad range of tools that we see in the space designed to support, monitor, or treat a variety of mental health conditions. And this includes really anything from wearables, general wellness apps, all the way up to actively regulated medical devices. And so as we see, for example, the FDA, they just had their Digital Health Advisory Committee meeting, talk about digital mental health technologies and products in general, DMH products. In contrast to that, when CMS talks about digital mental health therapies, we can go to the next slide. We have a very specific definition for that, or digital mental health treatments. These are DMHT devices. We can think of this as a subset of DMH products, and this is really where CMS is focused. As you see that definition that's there on the screen, I won't walk through each of the elements there, but we see that it's very much in alignment with CMS's requirements for eligibility for reimbursement under the DMHT codes. And so just kind of a baseline to keep in mind, DMH products in general are continuing to evolve, and we see a lot of different considerations about those. CMS's primary focus now is on this very small subset of those devices, which they consider to be DMHT devices that fit a very narrow band of eligibility requirements. And so as we talk about the different elements, we'll just make sure that we're in alignment with what is the context that we're using and which type of product are we discussing. Thank you. So I wanted to also hit quickly just a quick history of coverage for DMHT and DMH products in general. We've seen this evolution over the past, 8 or 9 years. Before 2017, we didn't really have many explicit CMS coverage pathways for digital therapeutics, particularly in the mental health space. And so we see this rise of devices and products that are kind of leaning on the gray area that we have with general wellness. As the technology has advanced, that gray area has gotten more complex, and is what FDA and CMS are trying to tackle right now, is how do we address these devices or products operating in the kind of this general wellness with potentially some medical claims that they're pushing, but they don't really fit into any of our existing pathways. In 2021, CMS finalized what was called the Medicare Coverage of Innovative Technology Rule, or the MKIT rule. I don't know if that's what it's actually called, but that's what we'll term it now, the MKIT rule. What this rule would have done is it would have created automatic coverage for any device that received FDA breakthrough device designation. It would have provided 4 years of automatic coverage for any of those devices. As CMS kind of went through the details of how do we actually implement this, they started to identify a lot of problems and challenges with actually implementing it. And so they repealed the rule later that same year. And so we don't see the automatic coverage for devices in this area that would fit into that. That has been replaced by other programs, such as the Transitional Coverage for Emerging Technologies, or the TCET program, which is also tied to FDA breakthrough designation, but also has additional requirements and doesn't provide automatic coverage. It just provides another pathway for reimbursement. The limitations we see in some of those other programs that have replaced the MKIT rule really are going to impact the ability of DMH products and DMHT devices in particular to really leverage those. And so we see kind of the shift away from that general coverage, automatic coverage, to these other targeted coverage pathways. From 2019 to 2023, we do see quite a bit of expanded reimbursement for remote care and virtual care monitoring services, particularly in the realm of RPM, remote physiologic monitoring, and RTM, remote therapeutic monitoring. Especially of note there is the adoption of the RTM codes for cognitive behavioral health in 2023. We've seen it be adopted, but what we see from that code in particular is there's been a lot of challenges in adoption or in uptake of the code. There's been very low utilization. The RTM code for cognitive behavioral devices itself did not receive any kind of national payment amount, and so it got kicked over to contractor pricing with the MACs. And that process has been very difficult. I don't know of any companies personally that are currently utilizing that code successfully. And so we still see CMS talk about how there's very low utilization. And the challenges around that RTM code, unfortunately, are many of the same challenges that we see transfer over to the DMHT codes that we'll talk about in a second. And then in 2025, we have the adoption of the DMHT codes with additional expansion of those codes here with the 2026 physician fee schedule. So just kind of a quick history of where we're at. Now, diving into the DMHT codes themselves, we have these three codes. We have G0552 for the supply of the device and initial education and onboarding, G0553 for the first 20 minutes of monthly treatment management services, and G0554 for each additional 20 minutes of monthly treatment management services. The structure of these aligns quite a bit with the structure that we see with the RPM and RTM codes, but there are some distinct differences, and you can see the language that's adopted there that adopts specific requirements for eligibility for use of both the supply of device and the monthly treatment management codes. One of the differences in particular that we'll just call out right off the top is that unlike supply of device under RPM or RTM, those codes are a monthly cost. The G0552 is for the total cost for a course of treatment, whether that treatment is 3 weeks, whether that's 8 weeks, whether that's 16 weeks. The G0552 is a single payment for that course of treatment for supply of the device. It's not a monthly code. We do still have the monthly elements with G0553 and 554, but not with the supply of device code. We can go to the next one. So under those, there are a lot of requirements for eligibility, which is the challenge that we're kind of facing now. And so I wanted to break down kind of piece by piece what it takes to be eligible for these current codes. And so over the next two slides, we kind of walk through that, and then we'll be able to talk about the changes that we've seen from 2026 and some of the challenges and progress that we've seen made in this area. So as a baseline, to be eligible for the DMHT codes, most of the requirements are tied to the device eligibility. And for that device to be eligible, it needs to be cleared by the FDA under a 510(k) submission or granted de novo authorization. Now, there's other FDA pathways that exist, but those other pathways under the current terms the CMS has adopted will not be eligible for reimbursement. Now, there's a little bit of conflicting language in the physician fee schedule where in the introduction section for DMHT, CMS talks about how they want these codes to be applicable to any kind of product that is cleared, authorized, or approved by the FDA, which language would indicate that a pre-market approval or PMA pathway would also be eligible. But then that's kind of explicitly cut out when we get to the eligibility requirements for the device. What this means is that if a device has really low risk or no risk to the point that the FDA doesn't want to require a 510(k), so it's either 510(k) exempt or the FDA considers that it will operate under enforcement discretion, those won't be eligible for reimbursement. At the same time, a device that has potentially higher risk to a patient and therefore gets classified as class 3 and requires a PMA approval process with the FDA, these reimbursement codes wouldn't apply to that device either. So eligibility is really kind of narrow to just the devices that fit into that middle band, where it's going to be a class 2 device with moderate risk to a patient that's under a 510(k) or a de novo. And that kind of creates some complications for us that we can talk about down the road. In terms of that FDA clearance or authorization, it does also need to be classified under one of these two regulatory sections, 21 CFR 882-5801 and 5803. These are for computerized behavioral therapy devices for psychiatric disorders and digital therapy devices for ADHD. What we see with that is CMS really kind of focuses their discussion on the fact that these two codes or these two regulations include a requirement for clinical validation of the efficacy of the therapy model, as well as how that therapy is delivered by the device. And that's really what CMS is leveraging. What CMS wants to see at the end of the day is that the clinical benefit of a device justifies the cost from CMS. CMS is a payer, essentially, and so they're worried about that cost benefit analysis. Unfortunately, CMS doesn't have the resources or really the inclination to dive into a cost benefit analysis for every device. And so they've kind of kicked that back to the FDA to say that because FDA is responsible for patient safety and efficacy, we're going to leverage that efficacy element to limit reimbursement for devices that have proven their clinical validity to the FDA. One of the challenges we run into with that is that the FDA's approach to this is, again, patient safety and efficacy. So they're looking at it from a risk-based perspective. And so the clinical validation you present to FDA is going to address whether the clinical benefit of the device justifies or outweighs the potential risk to the patient, but it doesn't take into effect any of the cost factors, which CMS is really worried about. And so we need to have that clinical validation at the moment, but it does create some challenges for us as we look at evolution of the code over time and expansion to other areas. The third one here is that furnishing of the device must be incident to a billing provider's professional services in association with ongoing behavioral health treatment under a plan of care. This is just the idea that the provider needs to be involved, it needs to be part of an established care plan, and it needs to be included in with the provider. We can go to the next one. And these last four are some of the ones that have given us challenges as well. The first is that the provider has to incur the cost of the device. That's a big challenge, right? We can talk about the challenges we've seen with physicians or providers who aren't familiar with this type of reimbursement model, having to wrap their heads around the idea of that they need to incur a financial liability, a cost to furnish the device to patients, and then hope that it gets reimbursed under the current reimbursement structure. That's been a significant slowdown in provider uptake and buy-in. The second one is that the practitioner has to prescribe or order the device. Again, for some providers who may be able to order these, that's a process they're not familiar with. And so we do run into problems with that as well. The patient does have to be diagnosed with a mental health condition. Originally, the language from CMS indicated that it was the prescribing physician or the billing provider that needed to diagnose the patient with a mental health condition. CMS has clarified in the last physician fee schedule that that's not the case. Any qualified provider can diagnose the patient. The patient just has to have that diagnosis before the device is ordered and can be considered eligible. And the last one is that use of the device has to be consistent with the indicated use in the FDA classification. What this means is providers won't be able to get any reimbursement if they use it in an off-label setting, or if they feel that a device in a particular therapy mode is useful for a patient that doesn't quite fit the target population under that clearance by the FDA, there won't be any reimbursement for that. And so we see kind of this narrowing of what we're going to include in these areas. So changes that we see in the 2026 MPFS are really targeted around the question of how do we expand use of these devices and reimbursement coverage to other areas that don't fit into that very narrow section of FDA cleared devices under those regulations. We do see expansion of reimbursement to include devices under 5803, which is that digital therapy device for ADHD. And much of CMS's conversations in the physician fee schedule kind of revolve around why they're expanding it to that one and not other potential device classifications or other target areas. And we can learn a lot of lessons from that about what CMS is focused on and what we can do within the industry to kind of move the conversation forward in those areas. We also see a correction of the code descriptor language for G0553 and 554 to clarify that that 20 minutes of time for each of those codes doesn't have to be time spent monitoring data received directly from the device. This is language that used to apply to, for example, RPM and RTM, had to be data coming from the device that was being monitored. Um, the language descriptor that we have for DMHT devices is much broader. And you can include any time used to analyze or monitor any information related to the patient's use of the DMHT device, even if it's not generated directly through the device or patient generated in direct relation to that. The third one is that we do see clarification, as we noted, the patient has to be diagnosed with a mental health condition, but it doesn't have to be the provider, the billing practitioner themselves who makes that diagnosis. This is going to be very important for a lot of clinical workflows where we have clinicians who are able to order the device, but haven't been, the initial one doing any of the diagnosis. We can have referrals back and forth and make sure that patients are getting the care they need across a variety of care situations. So that's just kind of like a very quick baseline of where we're at and what we have. Um, and I'll hand it off to Lisa. What we wanted to do, I think, was dive in and just kind of have a deep discussion on what this means.
Yeah, thank you, Michael. And I forgot to introduce myself. So I'm Lisa Palko. I'm the executive director for the society. And I wanted to thank Michael for providing his insights. We do have several questions coming in. So maybe we could get to those and then we can talk a little bit more about some of the implications of the CMS definition of devices versus FDA when
Yeah.
it comes to that. So the first question I see coming through here, and it's actually interesting. So would ongoing behavioral health treatment include a pediatrician or primary care provider's treatment of ADHD with prescription meds, even if that provider is not already providing psychosocial treatment?
It's a really
So,
good question, right?
right?
Um, what we see from CMS is they've kind of walked back some of that language to indicate that they intend for these to be used broadly by any provider that has authority to treat mental health conditions, including ADHD. What that ongoing behavioral health treatment needs to be. They don't specify whether it needs to be psychosocial treatment, behavioral treatment, or medication. And so, in the context where we have a primary care provider or a pediatrician providing treatment to a patient for a behavioral health condition like ADHD, even if it's just through medication, that would qualify for reimbursement under this as long as the other elements are met, right? As long as they have been diagnosed with ADHD, it's being that the plan for therapy or for treatment for it has been established in a care plan, that the provider is furnishing the cost of the device to provide to the patient. If all of those elements are met, then that will perfectly allow for reimbursement under that situation.
Great. Someone else asked, is there any category for prevention of mental health conditions?
That is a growing concern, right? What we
Right.
see in the space is there's a lot of focus on, and this kind of goes back to the idea of general wellness versus acute clinical therapy for identified conditions. Um, Currently, reimbursement for the code is limited to when there's an identified and diagnosed mental or behavioral health condition, and there is ongoing therapy for that. Now, if a patient is diagnosed and then use of a device is used to help prevent relapses or to kind of prevent escalation of the condition, that arguably would meet the requirement for reimbursement. But purely preventative, where there hasn't been a diagnosis of a mental health condition in the first place, wouldn't qualify under this code. We do see, though, that from CMS, there is an increase focused on kind of upstream drivers to mental health care and overall just general healthcare. And so hopefully we can see something for that move in the future, but under the current DMHT codes, it wouldn't apply.
Right. And I think that's an important distinction. The way that CMS sort of defined this and created this is based on the treatment of these, and not, there's certainly products that are out there that provide diagnoses, right? But this CMS reimbursement is specific to treatment. So,
Yeah, and I think that hits on another question that we often get, which is, we have these RTM codes that we talked about that exist.
mhm.
We have now the DMHT codes. How are they different? Why do we need it? Some of the comments we got from the original 2025 physician fee schedule we're to the vein that we don't need DMHT codes because we have the RTM codes. And so I think that's important to recognize that they do have different purposes. Um, and if you're okay with me talking about that for a minute, I think
Yes,
we
please,
get that question a
please.
lot. So an easy way to think about it traditionally was that the remote therapeutic monitoring codes were originally intended to monitor therapeutic response to therapy. And so you're looking at the patient's progression, adherence to therapy, things like that, but it's a passive monitoring of their condition and their response to the therapy that you're delivering. The DMHT codes are intended instead for direct delivery of that intervention. And so there's less focus on the passive monitoring and more on the active intervention. Um, we do see a little bit of that change with the recent changes to the RTM code, where CMS has recognized the RTM codes can be used for therapeutic, services sometimes as well. That's going to include that, but it's not the primary core purpose of it. Um, and we see CMS talk about the difference of, if a provider is doing both, how do I decide which one to bill? Essentially, the answer is if you can bill the DMHT codes, then you should be billing those ones because it's a more specific code. If you can't bill the DMHT codes for some reason, then you can look at the RTM as kind of a general backstop. But those are intended to only be used when there's not a more specific one that you could leverage, which in this case would be DMHT.
Right. And so you mentioned the RTM for CBT, which would be for those products that are not necessarily covered under this reimbursement under those two CFRs.
Correct.
Correct.
Yeah. So if you don't fit into one of those regulatory categories with the FDA, or if you're operating under, enforcement discretion, or if you have a classification that's 510(k) exempt because you're not presenting really any risk to patients, you wouldn't qualify for DMHT, but you could still qualify for the RTM codes for CBT. Um, you'll run into a lot of the same challenges in terms of contractor pricing, but there is a pathway there available. We just haven't been able to see very much leverage of that yet.
And you hit on the contractor pricing, and I wanted to sort of touch on that too regarding, I think in this latest PFS for 2026, they commented that they're continuing the device for contractor pricing. So could you just touch on that a little bit and how that impacts, quite frankly, perhaps the utilization of these codes?
Yeah, absolutely. There's a couple main considerations there, right? So from CMS's perspective, they are actively acknowledging that the current model they have for pricing services through the healthcare model has no idea what to do with software-only devices, right? It doesn't fit into any of their pricing models. It doesn't fit into any of the things that they've developed for either, physician practice costs or hospital costs. Um, And quite frankly, there's a lot of variability in the cost of the software devices themselves. So they don't even know where to fit it or how to decide what's important and what's not. Because of that, we're going to contractor pricing where they say, if you're eligible for reimbursement, you need to go talk to each MAC, and each MAC will determine what the pricing is that's appropriate for that device within this category in their local area. The challenge there is you have to do each MAC individually. The MACs are currently requesting different types and degrees of information. And so there isn't one consistent question that's being answered because the Macs all have to document it themselves. We also run into the issue that Macs need to justify that your device is reasonable and necessary for the Medicare population within their area. So even though we have the DMHT code that says if you've gone through this FDA pathway and you're certified in a certain way, you're eligible for reimbursement, the MACs still need to ensure that they have documentation that you are reasonable and necessary and appropriate for that older population that is the primary core of Medicare coverage within that locale. And so you see some MACs ask for clinical data and evidence. Even though you've gone through all the FDA stuff, they still want to justify that, the clinical necessity and appropriateness of the cost. We have questions about whether you can use invoices for customers, whether you need to have some kind of aggregated data that's there. So there's a lot of questions that are open there. CMS has acknowledged that there's some variability between the MACs, and they're trying to reach out to the MACs and get some consistency. but it was kind of, non-committal. So we'll see what CMS actually steps in to do. But for the current process, you do need to go through that process with each Mac. Be aware that Macs may require different types of information. It's going to be very similar, but they have different formatting requirements and things. And be prepared to have those detailed discussions on the reasonableness of your cost in light of your clinical validity, even though you've already gone through the FDA.
So that's an interesting, and just to touch on that a little bit further. So we have these codes. A product is fits under that code from CMS, but now they go to the Mac. Is the expectation that now the manufacturer, developer has to then provide data for the Medicare population, or is it something that they just need to be aware of, that they need to have a conversation, including all of the evidence that they have to make the case for that reasonable and necessary?
Yeah,
Because, and I'll, just for example, the new codes that are specific to ADHD. Well, we know there is a population that certainly in the Medicare population has ADHD. Um, Developers, and I worked for one, we just didn't study it in that population. So I'm just curious of your thoughts there.
no, absolutely. It is an interesting use case, exactly as you said. What we are commonly seeing is the Mac's primary focus is the cost element, right? They're trying to put a valuation on it. But within that context, they need to be able to document, because they have statutory obligations to document, that whatever cost they assign to it is reasonable and necessary for the population. So they may not require, separate studies or anything like that with the older population. What they may want to see is that, the pivotal studies that you submitted to FDA, did they include an older population? Was there any contraindication with age or anything like that? We're not sure exactly what they're going to ask because it's different across each MAC and in each situation, but you need to be aware that there is this underlying obligation for them to justify that. Their primary concern is going to be about costs and invoices, but there are discussions that may happen with the medical director or with the medical teams on, does the data that you provide justify its target towards this population. So we see with ADHD, for example, in particular, most ADHD studies aren't for older populations. They don't really include the target population that Medicare covers. So Macs may have specific questions that they bring up in terms of that reimbursement that they're not going to bring up with something for a different condition. We don't know exactly what they're going to ask until they ask it, but it's very important to be aware of it and be ready to have those conversations.
Right. And going on that, there's a question here about, are most Macs relatively new to engaging in pricing devices? I would argue yes. And do they talk to each other, or is that not allowed? Um,
Yeah. So, are they new to pricing devices? Not necessarily, right? We see local coverage determinations and things are a long history that we see with Macs. What they're new to is pricing software devices. So all of these challenges that CMS notes, like, we don't know what to do with this. We're going to give it to the Macs. The Macs are kind of like, well, what do I do with it? And so they're faced with that same challenge. They're new to that aspect of it. And so we're seeing kind of the evolution of how they're trying to tackle that. Um, do they talk to each other? I think there's some conversation that goes on, but they have to justify it for their local population. Um, and so it's really kind of narrow in that way, which is one of the challenges you have is if you want to expand nationally, you got to go through the process with every single Mac, and every single Mac may ask different questions. Um, Hopefully, CMS can provide some consistency, but again, we'll see where that goes.
right. Perfect. Okay, let's see. Someone asked here about, do you see any impact of PRDRS having on these payment schemes?
Yeah, absolutely. PRODURS is a fantastic area that's advancing. Um, these are prescription drug use related software that's intended to be used in conjunction with medication, which when we're talking about mental health conditions, ADHD, for example, having a medication along with a companion app that can help support adherence to your therapy plan or can provide additional tools and things like that is going to be really critical. I think we will continue to see an evolution in how we're going to integrate PDURs into this plan. Right now, CMS's focus is on just the device itself. Now, if we have, for example, if we have a digital mental health treatment device that is intended to be used as a PDURS, but also qualifies for all of the DMHT codes, that's going to be a new area that we'll have to see CMS kind of tackle a little bit. But as of right now, we can view them as if you fit under DMHT, leverage it. If you don't, look at the other pathways you have available to you. But I do agree that it's going to continue to evolve quite a bit over the next few years. I don't think CMS is really thinking through the implication of PDURs in this space as deeply as many in the industry. And so it's a good area to provide insight to CMS in terms of what is the appropriate approach to take on it. CMS is very open to information at the moment. And so the more that we can make our thoughts and concerns on that area voiced to them and addressed is going to be good, but they haven't really addressed much about it yet.
Right. And I think that's an important point. We see these call for comments for the RFIs every year. We just saw the one for the Gen AI medical device. We obviously, from a society standpoint, provide a video testimony. But someone had asked about, how from an organization can you encourage CMS to add more conditions? And I think that gets back to, ensuring you're working with your local organizations, work with us at the society, as we respond to these comments to talk about, expansion of these codes to other diagnoses as well.
Yeah, I echo that 100%. I'll just add to it. It's also very important to remember and recognize where CMS is coming from and what their primary concern is. At the end of the day, CMS is a payer, so they're worried about the money. They need to be able to justify that the clinical benefit provided by a device justifies its cost. That's really what they care about. And when we look at their comments through the physician fee schedule, over and over again, they talk about, there's devices that are going into the market. How can we be sure that they're providing enough clinical evidence for us to pay for them? That's what they're worried about. That is essentially a cost benefit analysis that they want to have. As I noted, they don't have the resources to do that on a device by device basis. And so them kind of deferring back to FDA and saying, we'll reimburse just for these regulations and these conditions is really because those conditions are the ones that have been cleared by the FDA with special controls that require clinical validation of the mode of therapy, as well as how that therapy is delivered by a device. And so, as we see with the expansion to ADHD, the reason they expanded to ADHD is because it had that same clinical validation requirement from FDA. If we want to really make a strong push for CMS to expand into a new indication, a new condition, what we need to make sure is that they have what they view as justification that there's clinical validity in the device, both in the mode of therapy and as the device delivers that therapy. And so if you're an organization who's looking at, I'm working on this area that doesn't fit into one of those categories, how can I expand coverage to me? The most effective thing I think you can do right now is ensure that your regulatory pathway includes special controls through the FDA that verify that you have clinical validity. If you have those, you have a much stronger argument as we go to those conversations with CMS that reimbursement should be expanded to that indication. If we don't have that, then CMS is going to be much more hesitant to expand coverage in those areas.
Right. Maybe if you could just expand on, what is it to have special controls? Because
Yeah,
individuals on the call may not be familiar with that.
definitely. So the way that FDA approaches things is on a risk-based approach. And so devices get classified as class 1, class 2, or class 3 based on the level of risk they may present to patients. Low-risk class 1 devices, those are going to be subject to just general controls like you have to register with the FDA, you have to use good manufacturing practices, you have to have documentation and adverse event reporting and things like that. If you have a moderate level of potential risk to patients, then you fall into class 2. And devices under this kind of higher risk class 2 are subject to all those same general requirements, but they're also going to have what are termed special controls, which are requirements that are added specifically to address the type of risk that your device presents. Um, when you go through a request for a new classification with the FDA, you as the sponsor get to propose what those controls should be to help mitigate and manage your risk, which is a great opportunity to ensure that you've got those controls that CMS is going to look for. But it's essentially it's FDA's requirement saying when we look to approve your device, we want to make sure that these things are in place to mitigate risk to patients and ensure that the efficacy outweighs the risk. If we include that requirement for clinical validation, then that's really what CMS is looking for. Most devices don't necessarily have that called out as an express second or special control. Um, we'll see if we see that change, but that's kind of what they're looking for.
Okay, great, thanks. And most of the devices that actually fall under this are the class 2 devices.
Right. Yeah. Yeah. So right now, the only devices that'll be eligible for reimbursement under the current DMHT codes are those class 2. There's a lot of calls for lower risk devices to get coverage as well. But again, because CMS is kind of deferring to the FDA's risk-based analysis in place of a cost-based analysis, we're at the situation where if your device provides incredible clinical benefit to patients, but doesn't have enough risk that it's going to trigger that class 2 regulation, then it won't be eligible for reimbursement. And so there may be some products that are looking at, do I intentionally increase the risk inherent in my product in order to be eligible for reimbursement, which is kind of a crazy position to be in,
Right,
but that's what we have.
right. No, and that was one of the things that they had asked for comments regarding, expansion to those that in sort of like the general wellness type in this most recent, and they decided not to open that, but they would consider it for future.
Yeah, yeah, and
Yeah,
it's interesting. We see two strong pushes. One in favor of expanding to those devices that have clinical benefit but don't present risk, and then we see a strong push from a lot of people who were afraid of again abusive cost and payment methods. That if we're not verifying the clinical validity in some formal manner, how can we ever justify the cost? And so the question is, is there another approach we can have to validating the clinical efficacy without kind of deferring it and trying to use that FDA process as a surrogate for what CMS really wants?
um, so there was a question here about looking at other countries and how they evaluate. And one was specifically looking at DIGA in Germany. And, is there a chance that CMS would ever pivot to sort of that type of program where it's sort of the HTA body and, which would be like like CMS is here. Uh, Thoughts on that?
Yeah, I mean, ideally that would be really nice, right? If we could have more of a systematic analysis of the clinical validity of these products come out from CMS to have kind of an across the board national payment, or even breaking it down into subgroups of these different types of devices will get reimbursed under different amounts. That would be ideal. CMS is very adverse to that right now. They expressly just say like we don't have the resources, and we don't really, again, we don't have the inclination, we don't have the desire to go through that right now. We're just going to defer to the FDA for clinical efficacy, and then we're going to defer to the MACs for contractor pricing. We may see them change as they get more data. Um, but the challenge is with the current obstacles we have to getting reimbursement, it's going to be slow to get data to CMS. And so what we don't want is we don't want them to point to low uptake because of the barriers that have been created as a reason for not doing a kind of systematic approach and analysis to get a national payment amount or something like that.
So, one of the questions, and we have so many questions coming in, this is fantastic. But one of the questions I wanted to ask is, you mentioned the low utilization, and because there is low utilization, I think it's important to call it out, but it's also important to emphasize that we need to continue to it's not a failure, right? These it's not a failure of these products. These products are are excellent and they have a role
Yeah.
in therapy. Um, we certainly need to have a better framework in order for reimbursement. But I think there still needs to be distinction there that yes, there is utilization. I think that was really expected given the complexity of this. From a provider standpoint, just understanding what actually can be reimbursed to, okay, make it into my workflow to have it reimbursed. And so I wanted to touch on that a little bit and talk about, how does CMS look at that low utilization?
Yeah,
Um,
absolutely. I think it's important to note as well that the process to go through to be eligible, if you weren't already eligible. So if you weren't already FDA cleared under a 510(k) under one of those specific regulations, and you're now looking at going through the FDA process, that's going to take a significant amount of time to then, once you get that, then go through the MAC contractor pricing process. That's also going to take time. So even devices that were ready to go that would fit under this but needed to meet the specific elements of eligibility, it's going to take a significant chunk of time for them to get through the process to where they can actually get reimbursement. And so CMS sometimes has a tendency to look at utilization numbers as, the totality of the view. That's not it. It's a snapshot of not who's interested in the space and who's making progress in the space, but that's just a snapshot of who's already finished the process. The process for eligibility here is not quick, depending on the use case, right? And so it's important to keep pressure on CMS to kind of advocate that there is huge need here. There is huge desire here. Providers want to use these devices to help patients. Companies want to be compliant with the eligibility requirements. They're making progress through the processes. The processes just take time. So we don't want CMS to just look at the number and not consider anything else. So we need to continue to be vocal about how happy we are that we've made progress, that we have the codes, that we're moving through it. We'll continue to refine them, but this is a huge win for the industry overall. It's just going to take some time for it to actually, trickle down and impact across the board.
Absolutely. So but how should providers and developers actually, what should they take away from this?
Um, it's a really good question, right? I think they have different challenges. Providers often have the challenge of how do I build a new model, reimbursement model into my workflow? If I'm not used to covering the cost of things, most mental health care providers, they write a prescription for a medication that gets filled by the pharmacy. They are not doing anything. So them wrapping their mind around the idea that I need to take on financial liability to cover the cost of the device and then ask for reimbursement when I'm not 100% sure how that reimbursement is going to go at the moment is a big thing. And so continued conversations and education on why that works, how that process operates, how we can build it into the clinical workflows is going to help providers with that aspect of it. Um, the highlight for providers that I've seen is that they recognize that these tools can be highly effective in helping their patients. And we need to focus that. Um, for manufacturers and developers in the space, they have to consider how do I communicate that to providers to get uptake? Because even if I get coverage, if no providers are willing to buy into my device, I'm not going to make very much progress. Um, so how do I do that in conjunction with the Mac? And sometimes having those conversations together can identify in this area that you want to focus on, what is the Mac going to need to see? How do I communicate that with the payers that I'm working with, and how do I leverage that into forward momentum?
And I think the other important point to consider is this is just based on CMS. What we're talking about today is CMS reimbursement. We certainly see private health plans or commercial insurers covering these products, and they might actually cover them under the pharmacy benefit versus
Right.
what CMS has put forth is your traditional medical benefit pathway. And so I think that's the other slow to adopt is, we as providers, we from a payer, former payer, we pushed from having these medical devices billed by providers to the pharmacy benefit. And now it's almost, we're taking a step back and trying to do it again that way. So I think it's just a matter of um, putting it into context and so what you see from CMS may not necessarily be what a commercial or state Medicaid plan would pay.
Yeah, absolutely. It's a very important, consideration to keep in mind. There's a lot of different pathways, right? We've had conversations in this field for um, all kinds of digital therapeutics of like what is the best pathway for us to get reimbursement. Um, and so we see progress with these DMHT codes. We also see a lot of obstacles. That doesn't mean there isn't progress being made in other areas as well, right? So I like that.
And then just a few more. If these products are going to be provided incident to, does CMS or anyone else have any role in educating clinicians, or is it up to companies to take on the full responsibilities? Love that question.
It's a really good question. Right now, it's kind of up to companies. I would love to see kind of formal documentation from CMS coming out around these codes and utilization and how to implement them in a clinical workflow. We haven't seen anything like that yet. So it is kind of up to companies to take the brunt of educating clinicians and getting them on board with it, which is a huge challenge. But the fact that we can do that is, small steps, right?
Right. And that's actually something that, I often think of that from a society standpoint, that's something that, we should consider. So whoever sent that, email me after this so we can talk about it.
Yeah, absolutely. Absolutely.
Um, and one last question here. They are working on a preventive mental wellness app, and I think we already touched on this. So it's not covered, but do you suggest we start from collecting data and applying to FDA? And I think you talked about that already, that, the pathway can be long and expensive for
Yeah,
some.
absolutely. I'll just note that be aware that the conversations you have with FDA about the data that you need to collect is different than the types of data CMS sometimes wants to see. So keep both of those in mind. But as you collect data, as you design, clinical studies and clinical validation, um, have those conversations with FDA early about what they're going to want to see, what kind of endpoints, what kind of data analysis are going to really justify the clinical validity of your device, and then work to make sure that whatever classification you get put into includes requirements for that validity, because that again is going to make that argument with CMS much stronger. I think there was just one other question that I noted that I
Okay.
don't think we got clarification on. So it was, what are the proper locations for office versus
Oh,
home?
that's it.
I think if I understand it correctly, it's a question about the place of location or place of service location code that's used to build things. I'll just note that we've seen a lot of shift in the telehealth codes and requirements for billing eligibility over the past, year as the telehealth flexibilities have expired. CMS is very clear that RPM, RTM, and the DMHT codes are not telehealth. And so the limitations on billing and some of the, place of service location code requirements and things like that that apply under telehealth situations don't apply the same to DMHT. And so look at the details, see how it's going to apply, but just be aware that it's not telehealth and it won't apply under those same rules.
Excellent. Well, I think this has been fantastic. And again, I want to thank everyone for joining us today. A huge, huge thank you to Michael for sharing his insights, his expertise on this. Um, at the society, we're here to support this and conversations like this. So make sure you follow us on LinkedIn. Join us. It to be a member, it's free. And we're in this together. So thank you again to Michael for sharing. And
Definitely. No, thank you so much for having me. We're seeing, final takeaway, we're seeing a lot of good positive progress. We have a lot of challenges that we're still working through. Um, but don't let that overshadow the progress that we're seeing. There are a lot of companies making really good headway, providing fantastic clinical benefit to patients, and CMS is aware of those. We just want to keep that at the forefront of what they're looking at so we can continue the momentum that we currently have while we address some of the challenges that we have. But I'm excited for this area and for how it continues to develop and for the Society of Digital Mental Health. Thank you again for having me.
oh, it's our pleasure. And again, thank you so much. And let's continue the fight, right?
Absolutely. Absolutely.
Have a good afternoon, everyone, or evening or morning, wherever you are. Thank you.
Thank you.